I'm going to go over the implant design. So one thing that a lot of you have had experience with was the old DePuy NuFlex implants that were a patent that I worked on in the 1990s. So KeriFlex is not reinventing the wheel. The NuFlex implant has a great 20 plus year proven success record. What we've done is Danny and I have worked, there are a few little things about that design that we tweaked and made better for the KeriFlex implants. So if you're familiar and have used the NuFlex in the past, this is going to seem very easy for you. DePuy stopped making the NuFlex, just so you know, because the silicone manufacturer in the US stopped supplying the raw material. So all of a sudden last year, everybody who used it, it stopped suddenly. And that was a bit disconcerting, certainly for me. We do know that the design was very well tolerated and also had a low fracture rate with better range of motion parameters. And this was from both Ian Trail's study out of Wrightington and Daniel Herren's study out of Zurich. The MCP implant is very close to the KeriFlex MCP implant is very close to the NuFlex design. There's some small changes that were made, but overall, if you look at it very quickly, it looks identical. The PIP implant was modified for better wear mechanics and better placement of the geometry of the stem in the intermedullary canals. As many of you know, the proximal phalanx portion of the PIP joint canal can have a very small diameter and small contour, and it's harder to get the implant to seat correctly. People have used tricks that Daniel will talk about, such as the broaching and rasping, and also using a Swanson burr to burr out the canal a bit. These do use the same pre-bend, anatomically neutral design of the NuFlex implants that's also now been copied by several other manufacturers. Next slide. So these are the implant on the top is an MCP implant. That's essentially what the KeriFlex implant looks like. The one in the middle is an old Avanta design that started this block design, and that has some advantages. And the one on the bottom is the Swanson that many of you are familiar with that does not have the block design. Next slide. When designing these things, one problem with the Swanson, which is remarkably successful actually for something that was designed on a napkin in a restaurant in 1960, it's got a fairly good track record, but it has very poor motion compared to better anatomically designed implants. And it also pistons because it's a bit smaller than the canal, so it goes in and out, and that creates wear debris. And the flat aspect of the implant without the block means that the extensor and flexor tendons are closer to the moment arm, so the center of rotation, and they have to work harder to get any motion in the fingers. And they tend to break at the distal portion. The Avanta, had an advantage of this block design, which pushed the extensor and flexor tendons away from the center of rotation, which gives more torque and allows the tendons to move the implant better. But it had a fairly high fracture rate due to the sharp angles that were present in the implant. Next slide. The NuFlex implant was designed with finite element analysis and reduced the silicone stress. It had a 30-degree pre-bend in the MCP and a 15-degree pre-bend in the PIP to more mimic how your hand rests naturally rather than a straight implant. And this has been demonstrated to improve post-operative motion. Next slide. There have been lots of comparative mechanical studies on the three implants, and the KeriFlex NuFlex design had far superior rotational and stability controls with respect to the intact center of rotation. Next slide. And it also the curve of the implant and how the center of rotation moved with each angle mimicked the natural intact joint much better than the other designs. So the advantage of the KeriFlex MCP PIP implants is that it maintains the extensor flexor tendon off center from the rotation axis. This provides more power, more torque. As you know, that's force times radius. So the radius from the center of rotation to the tendon. If that's greater, you have more torque, so the patient can move the implant better. It starts in an anatomically neutral position. When you rest your hand and you are not doing anything, your MCP joints tend to be at 30 degrees and your PIP joints at 15 degrees or so. So you're starting the stresses from where the hand normally rests rather than completely straight out. The junctures are smooth interfaces to reduce forces that can cause fracture. Better intermedullary canal fit, especially in the PIP joint. Superior quality silicone. There are implants out there currently today that have, I think, very poor silicone, and I won't use. They don't. They're a softer silicone than what's used in this device, and it should be fairly familiar to individuals who've used the NuFlex in the past. I'll let Danny start talking on the instruments next.
Thank you very much, Peter. Also, hello from my side. Good evening. Thank you very much for joining us. I would like to talk a bit about the instrumentation. So which steps of an implantation of a silicone implant require actually instruments? It's the resection as well as the endomedullary preparation. Everything else is kind of intuitive and doesn't need any special instrumentation. How about the resection? The resection guide basically is the trial implant. So we have, as you can see here on the left side, the MCP trial implants, which are available on the tray, sterile, which helps you in sizing. And sizing should be made on the table with the open finger, with the preparation, the way that before you cut the bone, you are ready to go for the implantation. You have to do this sizing. Usually it's quite obvious. And it's also easy to change if you probably go for a too small or too big one in the first step. It's also easy to change during the preparation and during the implantation. Just a few words about sizing of the implant. The good news is silicone implants are pretty forgiving. So even if your resection line is not completely perpendicular, even if you have some little spurs or little osteophytes around, silicone can compensate for that, and this has been proven quite a lot. So the resection line usually and typically is where in osteoarthritis the osteophytes are forming. So you can see if you open the joint from the dorsal side, the osteophytes coming, and it might mimic the joint line or gives you a different view on the joint line. So your first thing you do is you remove these osteophytes, and then you identify the collateral ligaments, the origin of the collateral ligaments, and as good as possible, you should try to preserve at least part of this origin in order to have a lateral stabilization of the joint later on. Usually you resect only on the proximal side. If you have a lot of osteophytes on the distal side, you can also trim the rims of the distal side, but the implants are designed the way that the center of rotation is in the middle of the head of the proximal phalanx, and this gives the best biomechanical results if you put it there. In the MCP joint, the collateral ligaments are a good anatomical landmark as well. Sometimes it's difficult to identify, especially in patients suffering from severe rheumatoid arthritis, having a lot of deformity in the joint. But nevertheless, here as well, try to preserve as much soft tissue as possible, also from the capsule, in order to get a primary stability together with the implant itself. Again, a few words about sizing. No, there are no strict rules. Again, silicone is a soft material, so it compensates in a way or other a little bit for mismatching. But here as well, like in all other implantations of joints, do not oversize. Oversizing always means tension. Tension means pain, and pain means a bad result in terms of mobility as well. Gives a lot of scars around. So you rather go one size less big than one size too big. So you don't have to fill out, there will be scarring around, and usually we have more problems in having not enough mobility than having an instability situation, especially in the PIP joint. If you put in the trial implant after resection, I will show you the technique in details later on. You have to check about the friction with the collateral ligaments and the capsule, but the design is made that it should fit pretty well. And I think this is the big advantage of the old new flex, that we made it flatter. We made it more elliptical, which fits much better to the shape of the PIP joint if you have resected the proximal phalanx head. If you have too much resistance in the extension, if you have the impression, and I'm talking about an impression, that it's squeezing together the implant, it's probably oversized. So it should be a loose seating in natural flexion, and it should be a visible open hinge in extension, and then sizing is correctly. What about endomedullary preparation? It's quite intuitive. The implants are going endomedullary. The endomedullary bed for a silicone implant doesn't need to be completely fitting the implant, because the implant itself will have a relative movement within the bone. So the instruments we need to open this medullary canal are on the tray, and they're pretty intuitive to use. We usually start, and coming back to that, again, about the pistoning issue. I think that's one thing we should never forget when we are implanting silicone implants, that the beauty of this implant, and probably also a big part of the success, is that it's moving around. So if we do flexion extension in those fingers, the implant is moving. So this distributes the forces along the implant and inhibits early breakage of the silicone. We have proof for that in the history. It was interesting because there was a phase in the mid-70s where they had the idea to coat the stems with Dacron in order to get a tight bonding of the implant with the endomedullary canal. And you know what happens? Within 6 months, all of these implants which have been brought in with this Dacron coating have broken. So this is kind of the proof that this pistoning is important. And you can also see the effect of pistoning in late follow-ups when you observe this sclerotic line around the implants in the middle and in the proximal phalanx for the PIP. For example, this is the sign of reaction of the bone to this relative movement. Again, the manual rasp are quite intuitive. We have the awl, which helps us a lot in opening the sometimes hard bone. As Peter already mentioned, drilling is a possibility, especially in the distal part of the PIP joint. Osteoarthritic bone might be extremely hard, and then you are better off in drilling. You can open the endomedullary canal with the awl and then help to widen it with the drill. Then we have a so-called starter awl, which is similar what probably some of you might be familiar with, the Swanson starter. It also gives you more or less the good shape of the endomedullary canal, and then the shaping can be made definitively with these specific rasps. We have a progressive sizing, which means with one rasp you can basically host all of these implants, and you have the marks on the rasping side in order to have the correct sizing and the correct shape of the endomedullary canal. This is the setup at the OR table. It's either an MCP joint tray, it can also be a PIP joint tray, or can be mixed together, so it all fits together. It's kind of a modular set, so everything is on the table, very easy to use, ready to use. I think I would continue now after giving this instrumentation part and go for PIP arthroplasty first and give you some details how to perform a PIP arthroplasty. We will see here a classical dorsal approach of the PIP joints. The The indications, at least in our hands, it's mainly osteoarthritic cases, but also post-traumatic destruction of the PIP joint, which are painful and functional disabling. And this includes the index finger. It's always a discussion about indication of having a PIP replacement in an index finger, especially also with a silicone implant. It's true that the index finger has quite a lot of forces which he has to resist with the use of the thumb, but we could have shown in several series which we published that the index finger doesn't have a higher revision rate than the other rays. Of course, you need functional attendance if you want achieve good results. Be careful in putting the indication, but that's true not only for the KeriFlex, but also for all other PIP implants with these disbalanced tendons, swan neck deformities, buttonite deformities. This might be a problem, very difficult to solve and give disappointing results, probably also not the cases to start with. Multiple previous surgery is also a relative contraindication and should be well considered. So you need to be sure that at least the flexor and the extensor tendons are in a shape that they have a potential to really function. Other than that, you can do a fusion right away. Instability is an issue. We observed, and this is in daily clinic as well as in the published series, if you have joint deviation which are significant, mainly over 30 degrees in any of the directions, it's very difficult to correct them with an implant arthroplasty, especially with a silicone implant, which is soft and has a bit less resistance than, for example, a two-component implant. How about mild swan neck deformity? Swan neck deformity is functional disabling. And it might be considered if you have a combination of swan neck deformity and the destruction of the PIP joint, that you can consider to go for an implant arthroplasty. If it's a mild swan neck deformity, and this should be the case if you consider that it should be redressable, so basically passively a free joint, and this might be a possible indication for a volar approach because you need additional stability in order to correct the swan neck deformity. And then the volar approach allows you to reinforce the volar plate, and also in the rehabilitation protocol, this should be followed as well. How about the choice of approach? Basically, there are three types of approaches. I just mentioned two of them, which I'm personally familiar with. Maybe Peter can give a word afterwards about the lateral approach. The dorsal approach is probably the one which is most popular to use. It's very versatile. It gives a very good overview. It's easy to identify the anatomy because we are used to look at the PIP joint and the PIP anatomy from the dorsal side. And it's also possible, which I think is very tempting, to do such an intervention in local anesthesia. I will show you that in a video of volar. The volar approach, definitely technical, more demanding. It has the advantage, at least theoretically, not to violate the tendons. So there are techniques which allow you to move the tendons away from the joint, the way that functional rehabilitation can start immediately without taking any concerns about tendon healing. The scar is hidden, might be an issue if you have several fingers, but if you do a straight incision on the dorsal side, usually the scar is very cosmetically very well tolerated. Again, what we have observed, and that's interesting, the volar approach has the least rate of postoperative swan neck deformity. It's kind of intuitive. If you have more scarring on the volar side, you have a better stabilization and probably some sort of preventing of the swan neck deformity, which sometimes we can observe in the dorsal approach, which tends to scar on the dorsal side the way that it pulls the PIP joint to the dorsal side. If you observe that in the early post-operative course, you have to do something against it, and for rehabilitation, for example, go for an extensor block in order to stabilize that. So what can you do? Here is the setup and the approach, local anesthesia. Again, I do meanwhile 70 to 80% of the PRP arthroplasty from the dorsal side in a finger block. I always use a straight incision. I try to keep the layers as much as possible intact. So I opened the skin and the subcutaneous tissue the way that I see the tendons, but that's it. I don't go too far to the lateral side. And then I detach the central sip with one straight incision going directly down to bone. So I really had my scalpel to the bone. I feel the bone and I do one cut. So I don't do any preparation of the capsule itself. I keep everything together. I think the more preparation you do in different layers, the more scarring you have post-operatively. At the beginning, I was very cautious in detaching the central sip. Meanwhile, I'm very generous. It facilitates the implantation on one side. On the other side, if you keep all the layers together, you can close them with one suture line and everything stays together and there's a nice scarring, and we almost never observed any types of insufficiency of the central sip reinsertion. I do the release of the collateral ligaments in a classical orthopedic way, so-called inside out. So I go into the joint. These are the shortest fibers, which are closer to the center of rotation, and I release them until I have a good view and a good mobilization of the joint. Again, what I already mentioned, sizing with a trial implant. I do then the resection freehand as good as possible, perpendicular to the bone axis. That's not very difficult to do that because you have a very good overview from the dorsal side. And again, I do only resection of the osteophytes on the distal side if needed. I don't do any formal resection. I think it's not too bad to have a bed of hard bone which the implants is laying against, and this also might prevent any rubbing of the implants with the bone. You have to be careful with resection of the dorsal central osteophyte, which is quite often present in osteoarthritis. It's part of the insertion of the central slip, and it doesn't do any harm. So you rather leave it or you just trim it the way that the central slip still has a good bed and a good place to scar on. This is then the resection box. Again, nice overview. This is in extension, so you can also estimate a bit about the sizing when you have done that. Then open the endomedullary canal. First, I always start proximal with the awl. Proximal, the bone is much softer and the awl is so pointed that it guides you into the medullary canal, and this fatty inside of the bone is just squeezing out. Then the starter rasp. I tend to really do 80, almost 90% of the rasping with that rasp, if ever possible, manually. And then final rasping with the sizing again, you know, from the trial implant, what size you're expecting, and then you can rasp up to the size which is needed. Distally, the same procedure, but here the bone might be hard, so open it with the awl first, and if needed, you can either go with the starter rasp or with a drill, with a burr, which helps you to find the endomedullary canal. Be careful, again, let you guide inside the bone. The burr tends to grasp the bone which is softest, so let the burr do the job and just be the guide of it. And then again, final rasping with the corresponding sizing, similar to what you have done on the proximal side. Then trial implant, put it in, see if it matches. Flexion extension, again, what I already mentioned, in a neutral flexion position, the hinge should be nicely opened. In extension, there should be still a visible hinge. If it's completely squeezed, you might consider a sizing smaller. Then insertion of the definitive implant. We always had learn know this so-called no-touch technique. I do it with the maximal touch technique. It's much easier. I never understood why this no-touch technique existed or not, but it's easiest if you do it by manually. It's very, very intuitive and easy to get it in. And then you check the movement, you check the stability. Again, the hinge stays nicely in place if the implant is moving. You can see here without any reinsertion of the whole soft tissue envelope, it's already pretty stable thanks to the form of the block and to the form of the implant. Let's move on. Then reinsertion of the central slip, always something to discuss. We stopped to do transosseous reinsertion. We observed some cases of swan neck deformity, which we think might be the result of this too tight reinsertion. If you just put together the envelope, I usually use a non-resorbable loop suture, which helps you nicely to tension that. The central slip will find its way of reinsertion almost itself. Let's put it that way. It should allow you active mobilization, which you can test directly on the table. So this is the same patient. No, that's the good thing about local anesthesia or volant, whatever you like to name it. But you can check immediately the range of motion, show it to the patient, which is psychologically very important in order to get him motivated for his later rehabilitation. Rehab is the next keyword. What we learned all over these, try to individualize. I'm not a fan of these really schematic rehabilitation protocols because we have so different patients. Some patients, I call them the losers. Losers in terms of if you see them after 2 or 3 weeks, they are already mobile until 90 degrees of flexion. And then we have stiffers, which is more frequent in Europe. Those who really get a lot of scars inside, having problems with mobility. And I think those different groups of patients need also a different rehab protocol. So you need a fit therapist, which helps you to identify those patients and work with them. We start with active mobilization always, passively if needed, don't overstretch it. You know, the central slip needs some time for being actively attached to the bone again. We give the patient some resting splint, basically for protection and comfort. If you have pre-existing deviation, body tape may help, but it's also possible, so this is the resting splint, but it's also possible to have these quite fancy hinge splints, which allow you mobility on one side and the other side, the implant and the joint is very, very nicely guided. If you have a very rigid situation, but I wouldn't do that in the first weeks, but probably after 2-3 months, you might even consider dynamic splinting. So we developed this outrigger splint, which can be used either for flexion or extension exercises and have a constant center of rotation aligned with the Fibonacci line of the joint, which is naturally made. And this allows you to enhance the mobility in those patients. I hand over now to Peter and give him the word to show us his technique of MCP arthroplasty. Thank you, Peter.
Thank you, Danny. So just a couple comments on the PIP joint. I think I really like, I have never tried Danny's exposure. I've always been nervous about taking the central slip, but I'm going to do it the next person because the view is spectacular, obviously. And every other way you do it, whether it's volar or this alternative oblique/lateral, whether you go between the central slip and the lateral band, which is what I usually do. I call it kind of the oblique exposure. It's dorsal, but it's also to the side, or a straight lateral. A lot of those, it's a little harder to get the joint exposed. And so this fillet open approach may actually be quite attractive. I'm going to give that a go. I've never done it. One thing I would say on the PIP joint, and as we talk about MCP arthroplasty, the basic technical aspects of putting the implant in is the same. I would say the PIP joint implant is harder to get in place than the MCP implant. The MCP joint tends to have a lot more laxity, and it's very easy to get the distal part of that implant in. The PIP joint, sometimes you'll put the proximal stem in, as Danny showed you, you put the block in place, and then there's very little room to get that distal stem in place. And so you have to be a little careful. You have to flex the finger. You have to use that forceps, but not rip the silicone. I definitely do the touch technique as Danny does, because you have to push at the same time with your finger to get it all to work. But once it snaps in place, and once that distal stem is in place in the PIP joint, it's extremely stable. And then the last point I'd make on the PIP is I agree with Danny that you don't want to overstuff the joint. You want it to fit, but don't try to get, if you're in between sizes, always go one lower. Next slide. So the MCP joint, as we know, this has changed a bit, the indications. In my practice now, it's far more osteoarthritis than rheumatoid arthritis. And when I started 30 years ago, it was far more rheumatoid arthritis than osteoarthritis. Rheumatoid disease really has been well controlled by some of the TNF blocker medications. And while we do see people like the photo on the left where they're overlapping knuckle joints, it's far less frequent, at least in the United States now, than isolated osteoarthritis. You do see some odd things like Dietrich's disease, where you'll get AVN of the head and things like that. But usually the typical person is a male who's 55 or 60 and has a middle finger, which is far more common than the other digits, a middle finger, and then the index is the second most common, isolated osteoarthritis of the metacarpophalangeal joint. They only get about 40 degrees of motion, and they have pain. Next slide. So for the osteoarthritic patients where you're doing a single knuckle, I tend to go also just like Danny's PIP joint, right down through the extensor tendon mechanism, right down the middle of the tendon, push the knife right down to the bone. And when I'm training the residents and fellows, they're always very hesitant to do this in one swipe, but you actually get a much thicker, well demarcated incision if you do that. So next time you do it, go right down through the tendon, through the, go back one. So right down through the tendon, through the capsule, and right down to the bone. And I generally will dissect the capsule out with a 15 blade a little bit from the extensor tendon so I can repair it separately. For rheumatoid patients, you can also go straight across the knuckles, as you see on the left, or I prefer to do 2 longitudinal incisions between the index and middle to replace those 2 joints, and between the ring and small to replace those 2 joints. Next slide. So the technique, I'm not going to belabor this because it's really almost identical to what you saw on the PIP joint. You do want to resect at the distal flare of the metacarpal, so right where the collateral ligaments are originating from. Usually the collateral ligaments come off when you resect the metacarpal head, and that's fine. I don't reconstruct personally any collateral ligaments except in the index finger. I used to reconstruct the radiocollateral ligament of the middle ring and small fingers, but I've stopped doing that over time. And very rarely, as Danny mentioned, do you have to do anything to the proximal aspect of the phalanx. Usually there can be some minor osteophytes, but if they're minor, I just basically leave them and I just prep it with the bone surface intact and don't really touch it. And then what you want to make sure, go back one slide, sorry, Danny. So you want to make sure an extension, as Danny showed, that the hinge isn't compressing too much against itself, so that it's well seated and not overstuffed. Next slide. And then inflection, as Danny showed you, you want to see that it opens up in hinging. And you can see that there's not a lot of pistoning in the KeriFlex design at the MCP. I think there's a bit more of the PIP. And there is obviously some in vivo when the patient actually uses some pistoning, but the hinge actually works like a hinge. And then I generally repair the capsule and then the extensor tendon as 2 separate layers. Next slide. So the resection level is a little bit further back than what you might be used to from the Swanson. You do want to be right at the distal flare of the metacarpal. So right where the end of the metacarpal flares out and then it starts going into the head. That's the ideal spot as the collateral ligament origin. And that will allow the block to fill up the space. And you can see on the x-ray, we've basically taken nothing off the proximal phalanx. That's de novo. Even a small osteophyte remains. Next slide. Now, a couple things, tricks. If you're dealing with somebody like on the left who's, and this is generally a rheumatoid patient, although rarely you can see an osteoarthritic with this, where you have overlap on the x-ray. So the metacarpal phalangeal joint head overlaps the proximal phalanx. You know what's happened in that case is that the proximal phalanx is underneath the metacarpal head. And this is a special challenge because in this particular case, when you have an oblique joint at the proximal phalanx, you will probably have to take some of that proximal phalanx off and make it perpendicular to the bone. So the order to increase the gap is you first, in the middle diagram, you first want to take bone off the head off the metacarpal. Okay, you leave the proximal phalanxes alone. Then you can stretch if you need a little bit of more space, but the bones are pretty good. You can stretch with your scissors, just stretch the volar plate a little bit. I've had some patients where I literally just stretch the volar plate so it's kind of shredded, and it will all heal back up. And if you can get the implant in that way, that's great. And then if you need to take a little bit, you need a little bit more gap, I take a tiny bit more, 2 millimeters, 1, 2, probably not more than 3 millimeters off the metacarpal first. So leave the proximal phalanx intact. And then if that's still too tight, then I would revert to go over to the proximal phalanx as a last resort to get a larger gap. You do want that gap to be large enough to fit the implant safely. And then in the index finger, I generally will repair the collateral ligament on the radial side. I make 2 little drill holes in the metacarpal shaft, the distal portion of the shaft. And after the, just before the implant is put in, I'll put a suture through the detached collateral ligament. I'll pass those sutures intramedullary and out the shaft. Then I will put in the implant, and then I'll tie that down. So the collateral ligament, it doesn't actually have to touch the bone. It just has to be in the right area, and it will all scar in and solidify. But usually it will end up touching the bone, touching where that cutoff part is. It won't go inside the intramedullary canal, but it'll touch the bone and it'll sock down and heal pretty well. Next slide. So in RA, I tend to prefer this longitudinal incision, which was taught to me by Jim Strickland, because when patients start range of motion, they're not, if you have a transverse incision, it tends to want to split the incision open, whereas if they're longitudinal, there's no forces to split the incision open. So it is a little bit, it's a little bit more difficult because you do have to do 2 joints through 1 incision, but you just cut the ulnar collateral ligament, excuse me, the ulnar sagittal band, because usually these tendons need to be centralized, and so you're going to need to imbricate the radial sagittal band to get the extensor tendon in the midline. Put your 2 implants in, and then centralize the tendons and close up 1 incision. And then after those 2 are in and the incision's closed, you go over to the ring and small finger and do those incisions. But again, the last person I did with a 4-finger rheumatoid patient was probably 18 months ago, and I will do 25 or 30 patients with osteoarthritis in that same time period. So at least in the United States, the incidence of significant rheumatoid disease has really gone down. So we have, there's a chat, you can ask in the chat box questions if you have any questions, and we do have, Danny has some cases to show too. So maybe Danny, I don't see any questions right now, so maybe we can, whoop, there's one, yep.
Okay, now first, give me a second for a few remarks on the MCP joint from my side, just kind of confirming what you said. I think I completely agree. The indication of MCP joint arthroplasty changed dramatically the last years. I think the cases with chondrocalcinosis, pseudogout, tends to produce a lot of MCP joint problems, and their implant arthroplasty at the end of the day is the way to go for those patients. And it's quite forgiving. Peter, just a question. I had the impression that those patients with single-digit involvement, these patients with hemochromatosis or chondrocalcinosis, they seem to have a bit less of mobility. They tend to get stiffer than the rheumatoids, or is it just an unproven observation from my side?
I can't honestly say that I have experienced the same thing, but you know, the rheumatoids have dropped off so much that I don't think it might not be a fair comparison anymore. I get patients routinely with the middle finger MCP joint that basically have near normal motion, 0 to 90 degrees. It's a very predictable operation in osteoarthritis. I have no qualms about doing it. I think the PIP joint's a lot harder because sometimes they will get some deviation and the patient's a little unhappy, and you know, it's a little more work. The MCP joint to me is just a slam dunk operation.
Okay, let's go to the question there. Francisco is asking, in which situation do you feel a pyrocarbon implant is superior? I probably would enlarge the question and say, when do you think is a two-component implant superior? Peter, I give you the word first. I think we have a similar philosophy, I guess.
Yeah, so for the PIP joint, I wouldn't use a pyrocarbon implant. I think there have been enough problems with it in that joint that I'm not really a fan of it. The MCP joint, sometimes I do think it's appropriate, especially in a younger patient. You know, you get somebody who's post-traumatic or is in their 30s. I do like to do a hemi procedure sometimes, just the head itself. So you got to watch those. Sometimes they'll squeak if they're not tensioned correctly. You can get kind of binding of the pyrocarbon, so patients will either lose motion or having squeaking of the joints. But frankly, I use pyrocarbons less than 5% of the time. I'm so happy with the MCP joint that I really don't. I tend to use silicone.
We have a bit similar philosophy. I think the basic advantage of two-component implants, and I think we have enough proof for that, is that they tend to have more lateral stability. So depending what is available, we personally prefer on the index and sometimes on the middle finger, especially if there is some pre-existing deviation of the joint, a two-component implant, because we can correct it at least in the mid and longer term, the deviation a bit better. Due to the fact that if we do flexion extension and there is compression of the joint, if the joint has some fit together and if there have some constraint in it, there is more lateral stability to it. I'm not a fan of pyrocarbon. I think that's not a secret. We published that on several occasions. It's a problem. I agree with Peter. If there is an indication for pyrocarbon, it's the MCP joint. Then is a few questions about collateral ligaments, especially in the PIP joint. What do you do with the collateral ligaments? I try to point out that if you have a severe deficiency of collateral ligaments, you might even consider going for a fusion than for an arthroplasty. We did on some occasions collateral ligament reinforcements or reconstruction. I got away from it. They tend to get so stiff, these fingers, that at the end of the day, you have some sort of a functional fusion. I don't know, Peter, what your philosophy is.
So I've become very collateral ligament agnostic. I don't really repair them except in the MCP index finger. The PIP joint, I don't repair them. The therapists do make a little gutter type splints so that they move in an arc that keeps them from deviating for the first 2 to 3 weeks. But I think they stick down and the soft tissues stabilize them unless you have a very severe preoperative deformity. And there's another question that's related to that of rehabilitation, the MCP joint. Frankly, I put patients in a right away at surgery in a P1 blocker splint so that the MCP joint is splinted at the 30 degrees, and the PIP and DIP joints are completely free to move. I put the joint that I am operating it on plus the 2 joints on either side in the splint. And I use that splint for about 2.5 weeks. And at 2.5 weeks in the MCP joint, I stop splinting completely except for nighttime use. And the patients just start, they're already doing therapy, but then they start therapy without any splint protection whatsoever.
I agree. We got away from these huge Swanson type of splints, where they could play on the harp. So we rather go for a some sort of splinting with the neighbor fingers if possible. Again, the indication of single digit involvement is much higher than it used to be. So I agree. Peter, I already said it during my presentation for the PIP joint. Yes, we do a silicone also in index fingers. We do PIP arthroplasty in index fingers. I know there is still publications coming from the US warning to avoid any type of PIP arthroplasty in the index finger. What's your personal opinion there?
Well, I do it in the index finger, and I've been very happy with the results. And I think that tide is changing. I spoke with Peter Stern recently about it. He's also basically dropped his original philosophical objection to that, and we'll do it in the index finger now. I think you have to discuss it with the patient. It is a finger that takes a lot of stress, especially at the MCP joint and the PIP joint. But I've been actually quite happy with the results. And you do see patients, especially osteoarthritics, who have both index and middle finger involved. The ring and small finger are rarely involved in osteoarthritis. It's really the middle and then the index second. But I don't have a problem doing it.
It's absolutely our philosophy as well. It's an interesting other question from Bernard. He was asking if it's recommended to do a PIP implantation at the same time with a DIP, whatever, I think fusion. Peter?
Yeah, I don't think that's a big problem. The only, if you do a DIP fusion and you happen to use an intramedullary screw, you want to maybe keep the screw maybe a tiny bit shorter than you might normally if the PIP joint weren't an issue, because you don't want the stem of the implant to, abut it. I've had that in cases where people have had a DIP joint fusion, then come later on for PIP arthroplasty, and there's not enough room because there's a Herbert screw in the middle of the DIP joint. And I just cut off the tip of the implant, and obviously the stem of the implant, so that it fits. You don't want to cut too much off, but I think it's fairly easy to get enough stem left in there that it's stable. And doing them simultaneously, I wouldn't have a problem doing that.
Yeah, I completely agree. We are just about to analyze our cases. Sometimes you have the impression if you do a double intervention at the same finger, it tends to swell a little bit, and this might inhibit a bit the mobilization. But meanwhile, I always go for it, because I think it's on the other side important that if you have a patient with double pain and you only treat one joint, he might have a problem in the rehabilitation because the other joint is so painful that he doesn't dare to move. So I think it even makes sense to go for these double interventions. Then there was a question of how about infection? I don't dare to say, because I think it gives probably a bad problem, but I don't recall to have had an infection in a PIP joint arthroplasty, the same as the MCP joint arthroplasty.
I agree 100%. In 30 years, I've never had one. I don't know why, because you'd think you'd get one, but I've never had one. If I did have one, I probably would, you know, if it were a real infection with pus, I probably would take out the implant. I would probably put in a methyl methacrylate kind of spacer in that area, close the skin, treat the infection, you know, with IV antibiotics. And then when you go back in to put the implant back in, because I would put the implant back in at some point, maybe 2-3 months later, you can take out the spacer, and there's a nice walled off area to work in.
I agree. I think it's interesting. Fingers don't seem to be very problematic in terms of infection, and we always give one dosage of antibiotics only 30 minutes before the intervention, and it seems to help. There was a question, interesting question about the use of the lateral pouch. To be honest, I never did it in a patient. I did it several times in cadaver because I always tempted to find new ways, and I like the idea not to violate the collateral ligament. And if you go from the ulnar side, you can preserve the most important radial collateral ligament. But I always had the impression, at least on the cadaver, that the dissection is bigger than I wish to have, because in order to really have a good overview, you have to go completely to the other side, and it's kind of stripping off the soft tissue. But Peter, do you have any experience with that?
I've only done a few. I don't have a big experience, but you know, I think you should do whichever approach makes you the most comfortable. So usually that's how you were trained. If you're trained dorsal or volar or lateral, do it because you're going to be familiar with it, and all of them have very good results in the literature from outcome. So I don't really have, you know, I think you pick what you're used to.
Absolutely. There's an interesting question about particle disease. Let's call it siliconitis.
Never seen
it. I have one case. I should have taken out this X-ray. I have one single case in a patient, and it's a very interesting story. She's a severe rheumatoid. She's more or less under control, even under biologics. So she has just quite a severe disease and quite an aggressive type of disease. I did implant arthroplasties first time 10 years ago. I had to revise them after 6 or 7 years because they broke, and she had recurrence, significant recurrence of ulnar drift. And then she's coming back, and she had problems with lymph nodes in the axilla. So she went to the gynecologist. The guy did a lymph node excision and found silicone particles in it. And he says, you know, he really advises to take that silicone out. So she has in the X-ray clear signs of silicone synovitis at the MCP joint. I've never seen that before, never ever. I was sending around the pictures. I sent it to you as well, Peter, to all my friends all over the world. Nobody saw it before. Very interesting. And the problem is then to do a revision in these cases is just a disaster. But other than that, I completely agree. Silicone synovitis is not an issue. You have to know that from the inflammatory standpoint, the silicone synovitis is initiated with a specific size of the silicone particles. So it needs a specific size to create this foreign body reaction. And obviously, unlike the implants in the wrist, in the finger joints, this particle size is not reached in a way or the other. But so I wouldn't be afraid of silicone synovitis.
Yeah, they're basically it's 300 to 400 angstrom size particles that cause this degranulation of the histiocytes. But you got to remember too, you need a lot of capsule, because the capsule is where all these macrophages live that are going to eat up the silicone. So if you have a large joint, relatively like the wrist, you're going to get silicone synovitis. If you have a really small joint like the PIP joint or the MCP joint that has very little synovium in the joint, you're going to get very little reaction. That's what why most people believe that silicone in the small joints has actually stood the test of time, where that's not the case in the wrist joint.
And interesting enough, we need this reaction, because this reaction gives us the secondary stabilization with the soft tissue envelope which develops. And if you do a revision, sometimes on these joints, it's quite remarkable how thick the capsule got. And this is kind of a foreign body reaction of the positives, of the positive type around these implants. There's another interesting question is, do you commonly revise with a different size or the same size of implant, Peter?
Yeah, so in the MCP, I think it depends on how long the revision is. MCP revisions in my practice are fairly rare. You know, maybe one every 2 or 3 years, and I usually can do the same size. PIP are much more common in my experience. I think the PIP joint just has more stress, and there tend to be more fingers involved. It's not uncommon to have somebody who has 3 PIP joints in one hand, whereas the MCP, it's much less. And those, I will usually do the same or one size larger, because when you go in, there has been a little bit of erosion of the intramedullary canal, and so it's a little bit bigger. And I tend to probably one size larger is the average result. The other comment I would make is when you do these alls or the rasps, a lot of times, what do you do if you're between a 30 and a 40 in the MCP? I'm talking about, not the PIP. PIP, I would do the smaller implant, but in the MCP, if I'm between a 30 and 40, let's say, and I want the largest size implant that I can put in there, because overstuffing is not as much of a problem. Usually, if you can only all to a 30 and you can't get a 40 all the way in the rasp, a 40 implant will fit. So you can take the trial and actually stick the stems in. And if it's sticking out like a millimeter from the bone edge, I would just use it. I wouldn't, it doesn't have to be totally flush. So it's very common that I'll rasp to like a 40 and I'll put in a 50, and it works okay in the MCP.
I agree. I think what I do is I always re-prepare the endomedullary canal. It's interesting, you find inside, you find this reaction around the implant, and I would make sure that the new implant which is coming in has the ability, at least in the PIP joint, to piston as well. Usually I also take the same size in most of the cases. And again, as Peter said, if you think that the bigger size is more appropriate and the stem has a problem, that's the beauty of silicone. Just reshape the stem and put it in. This is also a possibility.
I think it's great questions from the crowd, and a good turnout, and hopefully everybody can try it and see what they think. And if you have any other thoughts or questions or concerns or tricks you want, Danny and I are always available to help anybody. Appreciate your time.